Live now.
Good evening and late good evening for Professor Matthias and Abhay. Warm welcome to the 19th session of Active Learning for Pediatric Orthopedic Fellows. This session is after a short break because of the POSICON. We did not carry out our sessions for a few weeks, but again we are back. And then we have two interesting programs lined up for the next month. Professor Safik Pirani is going to have two lectures on basics of Ponseti technique for club feet. The aim of this session is to expose our fellows and the postgraduate to international experts on the topic. And today we are really fortunate to have Professor Matthias Axt with us, who is an expert and the champion of neuromuscular management of neuromuscular conditions in orthopedic patients. The topic is the use of gross motor function classification system in the decision making for orthopedic management. And Professor Matthias Axt, Abhay will introduce. But before that, let me give you some background about the topic, why we selected this topic. I will take you into the brief historical aspect. This concept, that's GMFCS, was initiated or was put forward in 1990s. And initially we thought that, okay, it's a good tool for the research. But after a few years using that in practice, I realized that it's a wonderful tool. And why I realized that it's very important, because before I knew the concept of GMFCS, all the patients who were coming to me, I used to say that it's not the surgery which is going to make a difference, but how much you make efforts, how much good physiotherapy you do, that's going to decide treatment. In some patients, I used to get good result. In some patients, in spite of good surgery, the same surgery, I was not getting result. And I used to tell to the physiotherapists that you are not doing proper physiotherapy. I used to tell parents that you are not taking enough care for physiotherapy. But later on, once this concept was introduced, I realized that it's not the problem with patients or with the parents, but the problem is about the GMFCS level of a child. You cannot get the same result in a child who is GMFCS level 2, and you cannot expect the same result in a child who is GMFCS 4. So for me, this concept has really made me to understand the outcome of patients. In next 10-15 years, people realize that it has a very important role for decision making, particularly as far as the therapy is concerned, and the type of surgery are important. So today we are going to understand that from Professor Axt. Before Professor Axt start his presentation, I request Abhay, who is with Professor Axt at present, he will introduce and give short introduction of Professor. Over to you, Abhay. Thank you.
Yeah, thank you, Dhiren. It gives me great pleasure to introduce Dr. Matthias Axt. He's a senior consultant here at the Children's Hospital at Westmead in Sydney, Australia, and is the previous head of the department. He's done his training and his initial work in Germany, in Heidelberg, and other tertiary centers, and moved to Australia about maybe almost 18 to 20 years ago. He's synonymous with dealing with complex neuromuscular conditions in Sydney. I'd say got patients traveling from almost the other end of Australia for care. So I think he's got extensive experience in neuromuscular conditions, cerebral palsy, muscular dystrophies, and there's a lot that our fellows can glean from his experience and knowledge. So I'm grateful that he's accepted your invitation to be faculty for us, and I want to thank him also for joining POSI. I think I'll stop with that and let Dr. Axt go on with the topic.
Yeah.
Abhay, thank you very much. That's for your very warm and lovely words, and also Dhiren, thank you very much. I would like to start with the talk. I think I can't share the screen. I think it's up to you, Dhiren, to allow me to share the screen.
Yeah, now you will be able to do that.
Right. So that should be. Okay. Let's see whether this works.
Yes, yeah.
Okay, can you see that?
Yes, yeah.
Excellent.
Just you need to take to the full screen. Yeah, perfect.
Yeah, so take, yeah, all right, good. Again, thanks very much. Darren, you have given a quick overview over the GMFCS, which was actually developed in 1996. I have this further down the track in this talk. And you also asked me to not talk too much about basics, but a couple of words I have to drop in regards to basics for certain reasons. I will explain why. So I start with what cerebral palsy is, and I started this because we don't only deal with cerebral palsy when we treat children with spastic conditions, but also with HSP. And HSP is very similar being treated. And we can actually also use the GMFCS. We say because the GMFCS is actually really only put down and labeled for cerebral palsy. So we then talk about the GMFCS equivalence. So cerebral palsy is a non-progressive disorder in the developing fetal and infant brain. And HSP, as we know, is a progressive disorder. That makes it a little bit different. But the basics and the basic treatment is still similar. And this is why I just wanted to mention this. I continue with how often actually cerebral palsy occurs, and I have the details for Australia. The prevalence in Australia is about 2.5 in 1,000. It's the most common physical disability in childhood. And I guess it is the same in India. We have about 34,000 children with cerebral palsy or patients with cerebral palsy in Australia. You should have, according to the calculations, about 3.5 million. And it's a big, big, big effort for you to take care of all those children. Unfortunately, it goes along with a lot of disabilities. So 1 in 3 children are not able to walk, and 1 in 3 children have hip displacement. And 2/3 of those children with cerebral palsy will need orthopedic attention. I continue with the classification of the cerebral palsy. And we know about the limb involvement, bilateral spastic, unilateral spastic, with the former classification into diplegic, quadriplegic, hemiplegic, and monoplegic. I don't want to go into details, but also very important classification is the motor type, like spastic, dystonic, dyskinetic, and ataxic. I mentioned this because 60% of children with cerebral palsy have a mixed movement disorder, so typically spastic and dystonic. Dystonia is a little bit of, I would say, causes a little bit of a headache. But we have shown in one paper out of our department that dystonia, in particular if it's mixed with spasticity, should be treated as spastic cerebral palsy exactly the same way, and we should not worry about having worse outcomes. Yes, we sometimes have unpredictable outcomes, but it doesn't justify that we do not treat those patients the same way like we do treat the spastic patients. So spasticity as such, we know the definition is velocity-dependent increase in muscle tone with hyperreflexia. The problem lies in the volitional control. So these children have lost control over their muscles or have partial control, and it varies quite a bit. They have selective motor control problems, and they have co-contraction of agonists and antagonists, and that plays a role in walking, and also leads to tertiary sequelae, which I will discuss in the following. I would like to start with the hold on, sorry, I'm a little bit jumping ahead. We also know that cerebral palsy as such, because it's a brain malfunction in some ways, also causes central weakness and a lack of balance, loss of selective motor control I've already mentioned, and a cognitive deficit. So while some of the patients across all GMFCS levels are very smart, we have to be aware that some patients won't be able to cope with the treatment options we could or can offer them. So that curtails what we do with the children. So the cognitive deficit is a very important feature which we have to consider when we treat children with cerebral palsy. So I quickly want to go through the GMFCS. We know in GMFCS1, children are able to walk all distances up and down stairs without holding onto rails. So they have quite good balance and they have only milder gait problems. Still, they have some lever arm dysfunction. I want to show you this video here. And this is a patient with GMFCS1, and you see that there's still marked signs of cerebral palsy, marked signs of spasticity. And you see even that if that patient wants to stop at the end of the walkway, the patient has a little bit of here. Did you see this? A little bit of balance problems. Still, this patient was able and is able at the time to play sport. Well, in the meantime, actually, the child also had orthopedic treatment. So in GMFCS2, we have a little bit more balance with problems with balance and lever arm dysfunction and selective motor control. You see this in this child. That child or person, it's actually not a child really anymore, is able to walk even distances and even on uneven ground, but has a lot more difficulties to control movements and also even to stop and to keep balance. So these children have to hold onto rails when they're walking up and down stairs, and we have to, again, as I said, curtail what we do with those children or persons orthopedically. In GMFCS3, these children are no longer really community walkers. They walk around house, maybe a school a little bit. This child uses a posterior walker and uses for medium and longer distance a wheelchair. But you also see the foot deformities limits mobility quite significantly. So we have increasing lever arm dysfunction at the hip, knee, and foot level, and I'll explain in a jiffy or in a little while what lever arm dysfunction means. In GMFCS4, so I had to turn this video around to make it work on Windows, and indeed it works. So GMFCS4 children or persons are non-functional walker. They have more significant hip, knee, and foot disease, and they have scoliosis in 45% of cases, which we also have to start to deal with. Those patients are typically no longer real walkers, even around house, and are reliant on wheelchair mobility, often electric wheelchair mobility. And then GMFCS5, these children have no head and trunk control, are completely wheelchair bound and dependent on outside help. They have hip disease, they have scoliosis in 80% of cases, and other comorbidities like epilepsy, respiratory disease, but also often feeding problems, which leads to the need of weight management. So they often need gastrostomy to be fed and to be kept actually in a good weight. So it's not that they are overweight, we often have difficulties to feed them enough to thrive. Lever arm dysfunction, I've mentioned this several times. And sequelae of cerebral palsy are in one case lever arm dysfunction, but also muscle contractures, bone and joint deformity. So explain the lever arm dysfunction best in this example of the femur, where in a normal person, when a normal person is standing upright and walking, and one leg in that case would be the left leg would be swinging through, the pelvis needs to be kept level and is pulled down by gravity. These forces of the pelvis being pulled down by gravity or by the ground reaction forces need to be counteracted by a lever via the center of rotation of the hip joint and the insertion of the hip abductors. And that vector that determines the lever arm. So in a normal person, we have typically 10 degrees of antitorsion or antiversion of the femoral neck. And in children with cerebral palsy, we have persistent antiversion of about typically, well, it depends a little bit, between 30 and 50 degrees, I would say. It's a little bit arguable, but it leads to a lack of abductor lever arm. I'm not sure whether you can see my cursor here. And it adds another extensor lever arm, which we actually don't need in that case, leading for the child to either sway with the upper body to the stance side to make up for this, or to internally rotate the leg to regain the lever arm. So this is hip lever arm, or the rotator lever arm is an important lever arm dysfunction which is inherent in cerebral palsy children or in all levels, but it gets worse with higher GMFCS. This is in children who are able to walk, often combined with external tibial torsion. We then talk about malalignment syndrome. So the hips are internally rotated, the tibia are externally rotated. Often we have foot deformities, which then leads to the feet being externally rotated, knees internally rotated, and none of the joints are in the line of progression as we want this to be. On top of that, we have in those children who walk with flexed knees, we have a quadriceps dysfunction where the quadriceps is firing all the time to keep the child upright, which leads to elongation of the patellar ligament, to patellar alta, and therefore to quadriceps dysfunction, which we have to take care of as well. Lever arm dysfunction also occurs to the foot. Typically, children start with equinus deformities if they are diplegic, and over time, with growth, with gravity, with pull of the gastrocnemius, and also with weakness of other foot muscles who can't maintain foot architecture and foot anatomy anymore, the foot breaks down into equinoplanovalgus. So the hind foot remains in equinus, and the forefoot moves and subluxes at the talonavicular joint and also at the calcaneocuboid joint. We call this a midfoot break, and the foot as such becomes a flexible lever arm, which doesn't fulfill the tasks of a normal gait like we have in what we call plantar flexion knee extension couple. This is a three-dimensional problem. The foot or the hind foot at the same time goes into valgus, and the forefoot goes into abduction. And clinically, this looks like this. On the left side, you see a child with GMFCS 3 with midfoot break, but still hindfoot in equinus and the forefoot abducted. The next photo shows much more deformity in a child with GMFCS 4, and the patient in the wheelchair has the feet completely out of the equation of any weight bearing. So this is not a functional foot, or these are not functional feet anymore. And this is a patient with GMFCS 5, not being able to walk. There's an X-ray as well added to show where the dysfunction is at the Chopard joint line. This is what we typically see in children with diplegic cerebral palsy, GMFCS 1, 2, 3, and 4 and 5 as well, of course, but we also talk about patients able to walk. Whereas in children with hemiplegic cerebral palsy, the architecture of the calf muscle is different. We have more rigidity and more shortening and earlier shortening of the calf musculature. And also the calf as such is a strong supinator, actually the strongest supinator of the hind foot, stronger of the and then the tibialis posterior. And that leads not only to equinus deformity, but often into equinovarus deformity of children with hemiplegic cerebral palsy. Hip disease plays a bigger role starting at GMFCS 3 and getting worse at 4 and 5. And we have learned that there's a linear correlation between the GMFCS and as what we call hip disease, and goes to, so hip displacement, hip disease affects 90% of children with GMS level 5. We know that spasticity is an important factor, but also muscle weakness as such, muscle imbalance plays a big role, and of course the lack of gravity. Those children, GMS level 4 and 5, not only suffer from spasticity, but they are not able to weight bear, and this is one of the reasons why the hips don't know how to grow, and they then sublux and dislocate as seen in this photo. What do we do? We quickly talk about management of hip disease. What we typically do, it can start at a relatively early age, down to the age of about 3. And we have learned also by some work, for instance, by Reinhard Brunner, who has examined the realignment via varus derotational osteotomy and Dega osteotomy, that children who are treated this way at a very young age often remodel back into valgus. So what we do here at our institution, we start at a young age, and if the child has significant subluxation, which we measure via the Reimer's index, and far more than 30%, we start. And if the child has spasticity and tight hip adductors with less than 20 degrees of hip abduction in hip extension and less than 30 degrees of hip abduction in hip flexion, then we release the hip adductors, gracilis, longus, and parts of brevis until we achieve about 45 degrees, but also in children GM level 4 and 5, the psoas at the lesser trochanter. This is a child who was lucky in this picture. The child has now a good hip with only soft tissue releases. However, we do know also from a paper research by Kerr Graham that the survival rate of hip adductor releases, so the hip survival rate with hip adductor releases at GMS level 5 is only about 15%. However, we are able to buy time and get those children into a slightly older age, like hopefully towards the age of 6 or 8, and then we can more safely do the hip reconstructive surgery. In our hospital, we have now also started to do guided growth. I've started about half a year ago in the hope that we get some positive response. I mean, this is a picture where we see there's acetabular dysplasia, but also coxa valga on both sides. There are institutions who have quite encouraging results, although they are not always 100% working. And I compare what we do here with the Melbourne guys, but also with one of my colleagues, Oliver Burke, who has started to do this in DDH, and he says that he has success with those medial guided growth surgeries. But if the hip is too subluxed, and I would say we start worrying about the hip when it passes 30%, but it really becomes unstable, and we often use the hip classification system, which has been developed by Melbourne. And if we have a hip class of 3 or 4, then we definitely have to do reconstructive surgery, and typically via VDO and also Dega osteotomy. This is a child with a 4-year post-op result, which is very encouraging. So these hips will hopefully remain stable over time. Now, the main thing, and I think the most important, the main part of that talk goes towards those children who are able to walk And I want to introduce what we do in our children, GMFCS 1 to 3. So the most important thing is that all those children undergo gait analysis. And we have learned relatively early on, more than 20 years ago, actually 30 years ago, really, that 3D gait analysis alters the surgical decision-making, and also that improves the surgical outcome, as found by Lee in 1992. If we base our decisions on gait analysis data compared to only the clinical examination. But that also influences further treatments. We call this often fine-tuning, since all of us do postoperative gait analysis typically 1 year after surgery, but also typically 2 or 3 years after surgery, because we know that changes happen not only after 1 year, but also even up to 2 or 3 years. We see improvements in management of those children via single event multilevel surgery. And it also validates the recipe. So if it's a beautiful tool to see and to check whether we have done the right thing to our patients. Before we even think about gait analysis and orthopedic management, we have to be clear with goals for our patients. And again, it depends very much what GMFCS these children are. So the goal setting is typically developed by parents or in combination with parents and the therapists, physiotherapists, and also occupational therapists, and the parents together with the child, collect or work out these goals. For instance, a goal to maintain or improve walking, keeping up with peers, but also looking like peers, changing the appearance of gait, no longer internal rotation, for instance, but also increase endurance, reduce fatigue, and improve stability. And often in cases, when it comes to hip management, in those children, GMFCS 1 to 3, because sometimes we add a little bit of varus if there's some acetabular dysplasia, which may help. We want to avoid joint degeneration-related pain, but it also appears, of course, to the foot and to the knee. If someone walks in knee flexion all the time, there's a very high pressure of the patella against the femoral condyles, which wears out that joint, the patellofemoral joint, prematurely. So gait analysis is also important, not only to check what we do with our children orthopedically, but if we can't manage those children orthopedically, what else we can offer to those children. For instance, botulinum toxin injections or selective dorsal rhizotomy at a relatively young age. We know the 6 S's. So one of them is around the age of 6. So relatively early on, we do selective dorsal rhizotomy here in our institution, but also medical treatment of muscle tone spasticity or other movement disorders, for instance, dystonia. Suitability of the patient for surgery also depends very much on the environment. I mean, we work here in a big center, but we also take care of children coming from rural setting, often 500 kilometers away, or sometimes even further away, towards central New South Wales. And we have to make sure that everything is set up for those families. So first of all, the family has to be well motivated, and postoperative management has to be available. So physiotherapy, for instance, but also the individual capabilities of the patient and themselves plays a big role, what we can offer them, and of course the GMFCS level. The movement pattern is another situation. I talked about dystonia quickly. It is easy to sort out a management plan for a child with consistent and repeatable gait patterns. You know, gait analysis, and one of those plots depicts one gait cycles, so from initial heel strike of one foot to initial heel strike of the same foot, divided into stance phase first and swing phase second, 60% stance phase, because there's 2 phases of double limb support included. Here in our institution, we have blue for right and yellow and red for left. The gray band is our norms, the Gait Lab norms. And we have in the first column the sagittal plane, second column we have the coronal plane, and the third column we have the transverse plane, and the levels, horizontals or pelvis, hip, knee, and further down should be, but I didn't put this down, should be the ankle level. So this is relatively easy. For instance, we can easily pick that in the transverse plane, the right hip is internally rotated. So for instance, that would be something we could be looking at. However, in other patients like this one, where there's a very dynamic range in movement in all planes and in all levels, it is very, very hard to make the right decision. Even if we see, yes, there is hip internal rotation on the left side throughout the gait cycle, but it is not up to me to make the decision whether this actually, if we only derotate the left hip, whether this changes the gait of this particular patient. So it's a little bit too much to do. So this is all being told to us and given to us via gait analysis, and this is why gait analysis is such a valuable tool. So what do we treat? We treat muscle and joint contractures, and then the sequelae of spasticity, and also often lack of gravity if the children are not walking too much, bone deformities, joint deformities, and lever arm dysfunction. In regards to soft tissue releases, we target the biarticular muscles if they are tight. For instance, we do a psoas release at the rim or over the rim to preserve the iliacus as a hip flexor, but also sometimes we have to target the hip adductors like adductor longus and gracilis if they are too tight. We target the hamstrings a little bit via semitendinosus transfer because we want to preserve the hip extension power of the hamstrings, but we want to weaken a little bit the ability to flex the knee, in particular if the hamstring or this hamstring, the semitendinosus, is very tight. We have to be aware that the hamstrings are very important hip extensors in loading response. In loading response, the body's inertia downwards is actually counteracted by the quadriceps and by the gluteus maximus, but also by the hamstrings. The hamstrings and the knee is being controlled by the quadriceps, so the hamstrings cannot flex the knee. Instead, they help, like a parallelogram, they help to extend the hip. This is why hamstrings are extremely important and shall not be over lengthened. The gastrocnemius level or the calf level, I will come back with the next slide. It is very important that we do not over lengthen the gastrocnemius complex. We are basically, I can tell very well, decisively, I would say, that in diplegic cerebral palsy, we should only lengthen the calf muscle in zone 1. Zone 1 is the zone where both muscles are present, like gastrocnemius and soleus, down to the junction between the two. So if we release the gastrocnemius from that junction, that's still a zone 1 lengthening. But another type of lengthening is the so-called Baumann procedure, where we dissect the gastrocnemius on the anterior upper neurosis only and leave the joints between the two muscles intact. Zone 2 is the level below the joint, or the connection between the gastrocnemius and the soleus, with the soleus muscle still present. And zone 3, the most powerful level, is where only the tendon is left over. So in diplegics, we should only do gastrocnemius lengthening and nothing else. In hemiplegics, all zones are allowed because the muscle properties are slightly different, and also so the muscles are more rigid, and we have to deal with a lot more equinus in many cases. So if we don't follow those principles, we risk iatrogenic crouch, like we have seen in the past. There's another paper being published by Kerr-Graham saying that at least 25% of iatrogenic and severe crouch is because of over-lengthening of the calf musculature, in particular in zone 3. We often have to stabilize the feet via lateral column lengthening or subtalar fusion. And I will show in the next, oh, hold on, sorry, I'm a little bit too early. We move on to correct lever arm dysfunction here at the knee. So if we have a lever arm or a knee flexion contraction of less than 10 degrees, we typically only address the semitendinosus, which we either transfer the adductor magnus or maybe to the medial gastrocnemius. And as I said, what about hamstring lengthening? If we lengthen the hamstrings or over lengthen the hamstring, what actually happens is that the pelvis tilts forward, and the consequences are that the psoas is no longer able to help with initiating a swing, and the patient is no longer able to walk functionally. We had, I remember in one clinical meeting when one of our senior consultants asked Kerr-Graham, who was visiting us, in a child who was presented in crouch gait with the knees quite significantly flexed, and the consultant asked Kerr-Graham, look, I've already lengthened the hamstrings. Shall I lengthen the hamstrings again to get this boy out of crouch? And no, this is the absolute wrong approach, because it only will tilt the pelvis further forward, and in the end, the patient is no longer able to walk at all. But we have to offer something else, and I'll come to this in a minute. So if we have knee flexion contractions of up to 25 degrees, age dependent, we can try, and it works actually really well, anterior hemiepiphysiodesis before skeletal maturity, or supracondylar extension osteotomy. Typically, at and over 25 degrees, supracondylar extension osteotomy is the way to deal with this. And because as a result, we have even more quadriceps dysfunction, because we relatively lengthen the quadriceps mechanism. We have then to shorten the quadriceps mechanism by patellar tendon advancement or patellar tendon shortening. There's a clinical picture here. In the forceps is the tibial tubercle with the patellar tendon. In those two grooves, so in the proximal groove is already the bone block from the distal groove where the patellar tendon with its block will be seated and then secured with a screw. And that actually works quite well. We typically will let those patients move their knees with CPM immediately after surgery to 40 degrees. And this, in my view, or in our view, shortens the postoperative rehabilitation. Lever arm dysfunction at the hip via antitorsion or antiversion is being treated with femoral derotation osteotomy. The dose is a little bit controversial. There were quite a number of papers out there trying to find the right dose of how much derotation you achieve. We found that going with gait analysis only and following the gait traces, we have underdone, or I have underdone in the past, the derotation a little bit, and so we have often or sometimes had recurrent antitorsion and internal hip rotation. So at the moment, my guess is that we need to derotate the femur about 10 degrees more than what the gait analysis tells us. And often we have to combine this with the opposite derotation of the distal tibia. Here's an example to line the foot up towards the progression. Now this is the case of one of the cases I would like to show. This is a child with lever arm dysfunction of the foot. The foot is flexible and externally abducted and unstable. The foot was stabilized via subtalar arthrodesis and talonavicular fusion. The pedography shows on the left side the left foot, on the right side the right foot, although it looks like it's reversed. The postoperative pedography shows that now the left foot is really a left foot and the right foot is a right foot. But what really goes to show here, if you see, unfortunately, we didn't have the gait lab available for some time a few years ago. So this is the same child walking. You see that the foot levers are flexible, but that's not really the point. The point is that this child is not able to fully extend the knees in stance phase, and the so-called, what we call the plantar flexion knee extension couple is destroyed because of the foot lever arm dysfunction. So after the foot has been restored, not only do we see that the gait looks much better on the video, but also this time we were able to do a full gait analysis, and we could see that the lever arm at the foot was restored by engaging the plantar flexion knee extension couple. All right, I move on. So I would like to show you a couple of treatment examples. This is a child, GMFCS level 1, with what we call a equinus, a true equinus gait. So the heels are always off the ground. And the hips are internally rotated. So this child is otherwise quite functional, has excellent balance, and you see actually in the gait graphs that the child is in true equinus and that there is hip internal rotation. And we treated this child with bilateral femoral derotation, hip abductor release, psoas recession. Psoas recession typically should only be done until the age of 15. Schwartz has published a paper saying that over the age of 15, psoas recession does no longer work. And this child was also treated with a zone 1 striated type calf lengthening, which restored gait function very well in all planes. So this is one example. Next example is this child, GMFCS level 2, with a very stiff right knee gait in severe crouch, because the gait graphs tell us that there's more than 30 degrees of knee flexion. The left side is compensating a little bit, but what is also striking, of course, the right foot is in dorsiflexion throughout stance phase, as seen in the gait graph. But the moment graphs show us that the child has to engage the quadriceps on the right side throughout stance phase in a way that this would be not sustainable long term once the child is fully grown and has and weight has also increased, because the child will at some stage get tired and will have knee pain and will no longer properly walk. So this child was treated because we found that while the calves were weak, the right side was long. And I have to say, this child previously had some soft tissue surgery done. That was done by me. And I did only a striated type calf lengthening on the right side. And you see, even with zone 1 lengthening, you can put these children into crouch gait if something happens, like, for instance, this child was completely lost for follow-up for several years. So that child also had knee flexion contraction on the right side and had bilateral patellar ulcer. On the right side, you also see the spur distally, indicating a significant I can't find the word right now, sorry. So pull all the time repair mechanisms and repair needs and wear at the distal patella. Sorry for that. So this child had quadriceps dysfunction with patella alta, and we treated this child with bilateral femoral extension osteotomy, with right distal femoral extension osteotomy, with bilateral patellar tendon advancement, and with bilateral semitendinous transfer. So you see in the gait graphs that in particular the knee, but also despite us not doing anything to the right foot, but the gait graphs were restored, which is also being shown in the video. However, what we do see that the third rocker is still missing because the calf is still long and weak. And that is also being seen in the moment graphs. So whilst the knee moments were nearly restored to normal, the ankle power was reduced to about 2/3 only, resulting in a lack of or in a diminished third rocker. So once the calf muscle is too long, it's very, very difficult or next to impossible to correct that. So I would like to show quickly demonstrate one of our papers from our institution about the management of GMFCS patients, because for quite a while, there was another colleague of mine was involved in the management. So the two of us, I would say, were the culprits of trying to make GMFCS patients better. So we had examined or followed up 31 patients, 2 years post-op, with the age between 6 and 17 years, and that were operated between 2004 and 2008. We had questionnaires which were answered by 23 patients, and we have the Canadian Occupational Performance Measure, which measures performance over time, and the GAS, the Goal Attainment Scaling, which depicts goals set by the patients and by the families in conjunction with the health workers, also particularly with the physios. We have obtained those measures from 15 patients. What we actually did, and it is quite clear that these patients had predominant knee problems, because we did a lot of, in most cases, we did hamstring releases, semitendinosus transfers, supracondylar extension osteotomies, and in some cases even knee capsulotomy to get those patients away from their crouch gait or out of knee flexion and hip flexion. So what are the results? It's interesting to see that 19 of the patients regarded the whole undertaking, which was significant, positive, because the families felt that we did a lot to these patients. We put a lot of effort in, and the parents honored this. However, in the COPM, Canadian Occupation Performance Measure, performance only improved in 7 patients out of 15 patients, which is less than 50%, although satisfaction improved somewhat. But in the GAS, which is a scale from -2 to +2, the patients self-rate their performance here. 9 of the 15 patients performed below the expected level. So we have to basically operate on more than 2 patients to get 1 good result, and that is actually not sustainable long term. We had a very high complication rate, and the highest were nerve palsy of the common peroneal nerve, because that was always or often stretched. We had some knee hyperextension, pressure sores, persistent pain, and of course also psychological distress. And children with GMFCS, they often do not really understand what's going on, and we put them through quite a bit. And this particular patient here, which is depicted, was admitted 3 months after surgery for not eating properly anymore, so for an eating disorder. So we, in the best interest of the patient, we thought we acted, but we didn't. Actually, we did not make these patients better. We in some cases actually made them worse. And this is why we have learned that we cannot improve function or even maintain function in patients with GMS level 4. So this is a synopsis of what we do at what GMFCS level. So we can safely say for GMS level 1, we can improve or maintain high level of walking. Whereas in level 2, we can maintain walking, but it's harder to improve it. In level 3, we maintain walking, but we also have to treat more and more hip and foot disease. In level 4, we have to treat spastic hip and joint disease, facilitate standing and care. And here it really starts that we have to try to preserve hip joints and reconstruct hip joints. But we also have to start looking after scoliosis management. And in level 5, we really only can treat the joint disease, in particular hip subluxation, dislocation, or try to keep those hips located and treat 85% of those children because of their scoliosis. So 85% of children with GMS level 5 will have a scoliosis, which is, well, treated in our hospital and often communicate with our spine team to work out what should be done first. Hips first, scoliosis first, or other management of the lower limbs, for instance, and also to facilitate care in the wheelchair as well as positioning in bed. So I want to show one more case, and that is a child, or actually at the time she wasn't a child anymore. She was already 16, and that is a bad, I would say a bad, it's GMS level 3B. A patient that is not able to walk properly, she's leaning in her walker to the left, very poor support on these terrible feet, with the left foot out, the right foot in, and with very stiff knees in a lot of extension, so 50 degrees of extension. And I really thought hard what to do with this person. She was very intelligent, which was a big benefit. And in the end, I did the whole program basically, so which was a bilateral supracondylar extension osteotomy of the femur, bilateral patella tendon advancement, left internal tibial osteotomy, and only on the right side we did something to the calf. And yes, she is still a GMS level 3, and she has still difficulties with motor control and selective motor control in particular. And she back knees a little bit, so she hyperextends her knees, but she does now functional walking and is able to balance her weight over her joints and also over the pelvis, which was a big benefit for her because in that, with that result, she could go to uni and study. So I want to finish my talk now and as a summary, put a couple of points together. And these are to set and accept the goals of treatments according to the GMFCS level, diagnose and treat lumbar arm dysfunction in the GMFCS levels 1, 2, and 3. The use of instrumented gait analysis in walkers is a must. Don't try to turn children GMS level 4 into walkers. Avoid hamstring lengthening whenever possible, and don't over-lengthen calves. Thank you very much. I stop sharing now.
Yeah, thank you, Professor Axt. Now I would request Dr. Abhay and Dr. Jayanth to have some interaction. Yeah, before that, can I ask a question, Matthias?
Yep.
Yeah, let's take a child who is like two child with the same scenario, the same X-ray. The pelvis X-ray shows that the migration index is 60%. how would you treat this child if he's GMFCS, he or she is GMFCS level 3, and the second child with the same X-ray, the child has GMFCS level 4? What will be the difference in the line of treatment?
Look, I had a couple of children GMSL3, and you have seen the child, the girl, which I've shown in the video as GMFCS level 3. She had hip disease, and I started to only derotate the femora, align the legs. I could also have shown her postoperative results, which was actually really, really good, and also correct the feet, but in a way that she could weight bear straight away after surgery. So in that case, I could not do a Dega osteotomy. So she had about 40% of migration, not 60, but 40. So I elected to do VDROs to start with, but I knew that I had to do Dega osteotomies on both sides, which I did 2 years later. And there was still enough time. But sometimes if these children are already older, it should be combined. So in a GMFCS 4 child, I would always combine the Dega with the VDRO, because I know that the stability, at least the mid-term and probably long-term stability, is about 3.5 times higher than if I do only VDRO in those children. But yes, depending on what the child needs for rehabilitation after surgery, it may be staged procedures, so that you allow them to weight bear. With a Dega osteotomy, they can't weight bear. They have to wait 6 weeks. And sometimes they are too deconditioned to make this happen in that particular phase. If it's SEMLs, it's a big, big impact on the children, and you want to get them back to walking as soon as possible. And then sometimes what we call fine-tuning or subsequent surgery may be done at a later stage. Did I answer the question, or is it?
Yeah. Okay. And then the similar question I would like to ask for the equinovalgus or the valgus foot. In GMFCS level 3 and 4, will your management will be different, like a lateral column lengthening, or you would go for something more additional fusion for the medial column or something like that in GMFCS level 3 and 4? Or you will not operate level 4 for the foot surgery?
Well, look, maybe I didn't mention this, but what we should still aim at for GMFCS 4s, we can't make them walk, but we can make them do standing transfers. Not everyone. It depends also a little bit on the motivation of the patient, on the family, and on the weight of the child, and on other comorbidities. But often they can do transfer walking. And in that case, I do stabilize the feet. And you have seen in my photos that GMFCS 4s have a lot more destruction of the anatomy, so a lot more deformity. In those cases, I always do a talonavicular fusion. I typically, because I've found that even in GMFCS 3 children, often lateral column lengthening is not enough. It only works for a couple of years, and then they break down again. So I have actually, moved away in many cases from lateral column lengthening. Only in very, very few cases I now do this. I rather do subtalar arthrodesis, and in more severe cases with subluxation of the talonavicular joint, I do a fusion, which is actually like a functional triple arthrodesis, but it still spares the subtalar or some of the subtalar joints, and also spares the calcaneocuboid joint. So there's some flexibility left over.
Okay. And
with regards to your initial scenario about the hip dysplasia between the 3s and the 4s, if I can just add another thought, both of them we would think of doing VDROs to help with the hip containment, but the degree that we will bring the neck shaft angle down would be different in both. So in the walkers, we would stay closer to 120, probably 125. and in the non-walkers probably closer to 110, maybe 100. So that's probably another difference in that would, change based on the GMFCS change the surgical technique. I think that those will be same thoughts from Dr. Axt as well.
Yeah, that's correct. Abhay, thanks very much for reminding me. That's true. So we try to preserve the physiological neck shaft angle in patients who are able to walk, but we vary a lot more in children with GML 4 and 5. However, we have to consider not to go under a certain degree, and I shy away from going far beyond 110 degrees because those children then impinge laterally and can no longer sufficiently abduct their legs.
Okay. Then there is a question which you showed a paper, which is very relevant paper for GMFCS level 4. Like the results are not that good, or we get results in only 50% of cases. So based on that paper, how have you changed your practice? So if you get a patient who is having a GMFCS level 4, do you still such operate?
Yeah. So look, the goals have changed. We published this paper 10 years ago, and before that, we thought we could turn GML 4 patients into walkers. We've learned that we can't do this. However, what we still can do is to try to maintain standing transfers, because it is for the family a much bigger burden if they have to hoist their children, their grown-up children, also the adults, all the time from one location into the other, from bed into the wheelchair, from the wheelchair somewhere else, onto the toilet, and so on. So it's always of benefit if those patients can do a very quick standing transfer, like stand up in the wheelchair, pivot towards the toilet, and then sit down. It's a big help, and we aim at doing this and maintaining that function for those patients. That also means that yes, in that case, we do lengthen the hamstrings, because those children are not functional walkers. We can safely lengthen the hamstrings. We stabilize the feet. We do hip surgery. Of course, we do, because 70% already have hip displacement. We stabilize the hips, but we also do releases, and quite liberal releases of hip adductors and of the psoas. And in children who are not able to walk, we typically release the psoas from the lesser trochanter instead of over the rim or at the rim, which we do in walkers.
There's one other slight nuance, I think, when it comes to GMFCS in the Indian population, and this is from more of my time that I'd spent in Vellore, is unlike say in Australia and Canada and other places where children get early intervention, a lot of physio very early in life, and have their GMFCS level probably closer to what it actually is when you see them. And so they may appear to be functioning at a lower GMFCS than what they actually are. And if you look at a lot of the papers, actually GMFCS is not an outcome measure. It's a classification system. So children shouldn't really change their GMFCS level after surgery. But very often, I used to find a lot of the kids that we operate on back home, they change levels. They seem to go one level up. It probably is that they're going to what their level was or should have been. And it's not really us getting them one level higher. They probably were always a level higher. They just weren't optimized. So I think for our population back home in India, we should not make that call of GMFCS the first time you see them, but probably after following up the kids a little, optimizing them, and then actually classifying them into what level it should be. I think that's a slight difference from the Western world probably.
Yeah, Abhay, what you said is very important for the fellows to understand that whenever we see a child for the first time and we determine their GMFCS level, we have to take the deformities also into consideration and the lack of physiotherapy. These are the two things which, like, suppose child is at level 3, but because of the flexion deformity at the knee or due to some feet deformity, the child may function at the time of presentation like at level 4. And then orthopedic surgery makes them or bring them back to level 3, which was their initial level, but because of the deformities, it was lower level at the time of presentation. So that is, I have seen also very frequently in our population, because most of the patients, they are not taking adequate therapy on a regular basis, which is there in Australia or Canada or in USA. So yes, this is one thing which we have also observed. Yeah. Just a last question, because already we have completed the time. So the question is like, how in your practice GMFC has changed the management to a great extent? One point, if you want to say, what will be that point?
Well, look, GMSL 1 to 3 has always been treated as for the same way, and we had similar goals. So the goals have not really changed from between 1 and 3, but it has changed in 4, and it also has changed in 5, because in Australia about 30 years ago, it wasn't a priority to keep hips stable. And we have seen terrible situations with oblique pelvis, with hip dislocations, painful, with scoliosis that were not properly managed. So what we have learned is, the most important thing we have learned is, I would say, two things or 3 things. One thing is to use gait analysis to optimize management in GMFL 1 to 3, scoliosis surgery to optimize the quality of life of these patients, and hip surgery also to optimize quality of life of those children. So maintain hip integrity and therefore reduce pain and make care easier for the children, but also for the carers themselves. One thing is, what we often see, that GML5 kids are very restless at night. If they have pain, they won't sleep through. So carers have to get up multiple times per night to look after this child, to reposition them, to give pain relief. So if we keep them pain-free, everyone can get to rest, the child as well as the carers.
Okay, so thank you very much, Professor Axt, for sharing your wide experience and the understanding of orthopedic management based on GMFCS level. And I'm sure that this is going to be very helpful to our fellows. And again, I request you to find out a new topic, because a lot of decision making is based on gait analysis. So if you can show us how you use gait analysis into decision making, then it would be very useful for us to understand, and particularly our budding pediatric orthopedic fellows, that what is happening in the experienced people mind and how to understand that understanding and apply that into the practice. So with that request, I thank you everyone, like thank Abhay, thank Jayanth and Professor Axt for, and again like the fellows for participating in this session. I understand that for fellows, this is bit a relatively early time, because most of us work till 6 or 6:30. So I really appreciate that you spare your time from clinical work and join this session. Thank you and have a great time. Bye-bye.
Thank you.
Thank you, Neeraj. Thank you.
Thank you, sir.
Yeah, thank you. Thank you, Devendra.
Thank you. Thank you very much for having
Thank
me.
you. Yeah. Bye, Abhay.
Bye. Good night.
Bye. Good night, Abhay.
Yeah.
Thank you.
Good night, Matthias.
Okay.